accessibility for gene therapy is still limited for hemophilia B. And there's one product that is now available in the US and also Europe. Fortunately, because of the high costs, it is not yet reimbursed in the Netherlands and also not in other countries in Europe. And so there's only a limited number of patients in other countries that have received commercially available gene therapy.
Welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA. I'm your host, Isabel Oliveira. Today, we have the pleasure to have with us Professor Frank Leebeek. Welcome, Professor Leebeek. Can you please introduce yourself?
Thank you, Isabel. Yes, I'm Frank Leebeek. I'm a hematologist, and I'm working in the Erasmus Medical Center in Rotterdam in the Netherlands in the Department of Hematology, which I'm also chairing as a department chair. And in EHA, I'm a member of the executive board and currently also a treasurer for EHA.
Thank you very much for being with us today. In this podcast, we want to go through your career and understand all you have done for this field. So how did you get into hematology?
My journey in hematology actually started very early in my medical studies. During a research rotation, which took about 5 months in my third year of medical school, we did studies in the Department of Hematology in the Erasmus MCA already on fibrinolysis in patients with cardiovascular diseases. And that's where my interest in hematology started. So during my medical studies, I kept performing research besides my studies, and also had the opportunity to publish some papers in hematology journals. And eventually, after 2 years of extra research besides my medical studies, I also obtained my medical degree and my PhD degree at the same time. I left for the United States and went to Chapel Hill in North Carolina to perform also studies on hemostasis and thrombosis. And that was a very nice experience because I learned lots of things in the laboratory, specialized in molecular biology, which was then upcoming. So I had the opportunity to learn lots of things doing PCRs, site-directed mutagenesis, to edit genes already and study the functionality of interleukin-6 in fibrinogen synthesis.
So hematology is a field where doctors are doing research. Is that one of the things that you liked about the field?
Yeah. Now, I think hematology, the broad field of hematology, so the classical hematology, benign hematology, hemostasis and thrombosis, but also malignant hematology is very interesting, especially because there are so many new developments over the years. Now, it started already many years ago, and in that time, there have been so many developments. I think that's unprecedented for any other specialty in medicine. And it's not only for malignant hematology, but also in classical hematology and in hemostasis and thrombosis. Many things have changed. And to be part of that, it was, of course, fantastic.
Is that field where the results of research are being integrated earlier to other fields?
Many people in the academic field are also involved in research. Because there are so many new developments, I think many people have the chance of performing research next to their clinical duties.
So you came back to Erasmus, where you have developed your career for many years. What do you think have been the highlights of this career?
Well, in the beginning, of course, you had to start again. I was away for a few years, and then during my residency, I couldn't do real research. But then you have to start with a new research line. And at that time, I was interested in the role of coagulation in the development of arterial thrombosis, especially at a young age. Why do people have a myocardial infarction or a stroke at a very young age? And so we started a study supported by the Erasmus MC, but also by the Dutch Heart Foundation. And those were things that really put me on the stage to do this research and to hire people, for instance, PhD students, and to mentor them. And that was the start, actually. And after finishing many studies on the role of coagulation factors in arterial thrombosis, including von Willebrand factor, LMT13, which we found were also involved in the development of arterial thrombosis. we gradually changed my research focus to bleeding disorders. And that was actually initiated by the fact that we saw in our department many patients with bleeding disorders, for instance, hemophilia. And that was an important part of my clinical work. So it's also logical to do your research more in that field of hematology.
Is this common in the Netherlands? So are the patients that have these conditions especially treated in Erasmus?
Yeah. That's very well organized in the Netherlands. So we have several hemophilia treatment centers, but the Erasmus Medical Center takes care of patients in the southwest region of the Netherlands. And we have about a quarter of the population of patients with bleeding disorders or for fibrinolysis disease, but also hemophilia A and B. So that means that we have about 2,000 patients with hemophilia in the Netherlands, and 500 of those, 400 to 500, are treated in our center. So you have the ability to perform clinical studies, also studies with new drugs. So if you want to do research, do it in a topic that you also see the patients. So that was an important step to change your focus of research, which sometimes happens during your career.
So you're very well known for studies on von Willebrand disease.
Yeah.
What can you tell us about this?
Now, von Willebrand disease is actually the most frequently occurring inherited bleeding disorder. It's more frequently occurring than hemophilia, and we also have a large group of patients in our center. And at the time that I started with those studies, that's about I think more than 20 years ago, we felt that there was a lot of attention for patients with hemophilia, but there was only limited attention and limited knowledge also on patients with fibrinolysis disease. So that's why I started the Willebrand in the Netherlands study, which is a study that I coordinated, but collaborated with all the hemophilia treatment centers in the Netherlands. And we were able to collect actually all patients that were seen in the Netherlands in the hemophilia treatment centers with fibrinolysis disease. So that amounts up to about 1,200 patients. And most of them could be included in the study, which was a real accomplishment because it was the largest study at the time in patients with fibrinolysis disease, due to the fact that we cooperated as hemophilia treatment centers. So no competition, but collaborations. And secondly, because those patients were really interested to participate in studies because they have been overlooked for many years. All the attention went to patients with hemophilia or other bleeding disorders. So more than 80% of patients who we asked to participate could be included in the study. And that we took their history. We had a lot of questions regarding the burden of disease, quality of life. So they filled in a questionnaire of 90 pages. And so they all did. And we included patients from, let's say, 1 year to 85 years. So we had the whole spectrum of the disorder. And that led to many, many studies that we could perform in these individuals and also brought new insights. For instance, that these patients really have a reduced quality of life, especially in women who have frequent, of course, bleedings with the menstruation, bleedings after childbirth. And those were things that were, of course, known, but not in the depth of what we studied in our Willebrand in the Netherlands study.
What improvements have come for the patients from these studies on von Willebrand disease?
I think first there is more awareness of the disease. So it was a disease that was not really known by, especially in general practitioners, gynecologists are not so familiar with this disease. So by putting a lot of intention to this disorder, performing studies, making new guidelines, I think their treatment and also the awareness has increased over the years. Still not solved because there have also been many studies on, for instance, new drugs for fibrinolysis disease. Recombinant fibrinolysis factor became available, and now there are other drugs that are available. But still, there is a burden, especially in women with bleeding disorders. So, despite the fact that we have made progress, I think there's still a lot to gain. in the future. So that's why we still continue our studies. For instance, in the next study that we started, not the WIN study, but the WIN Pro study, which is a prospective study in which we followed patients, more than 600 patients with Willebrand disease in the Netherlands, followed them for 2 years, looking at bleeding symptoms, but also surgeries, etc., drugs, medication, to obtain more insight on the prospective evaluation of bleeding symptoms.
So there is still a lot to do.
Yeah, we are still busy, also we've seen a lot of PhD students who have done this work in the past 20 years, and there are some new PhD students who will start.
So you're also associated with hemophilia research. You were involved in the treatment of the first patient with gene therapy for hemophilia. What can you tell us about this?
Yeah, hemophilia has been a disease that has been treated for many decades with coagulation factor concentrates, and first with plasma-derived coagulation factor concentrates, later on recombinant factor concentrates. But there were not many advances in the field. And actually in the past decade, that has changed tremendously. Several new drugs have been developed, even monoclonal antibodies to treat it, but also gene therapy. And that occurred about 10 years ago when we were asked to participate in a clinical trial. It should be a phase 1 trial of a drug developed for hemophilia B, gene therapy, AAV-based, which was a one-time infusion. The idea at that time was that we can change the phenotype of a patient with severe hemophilia to a patient with mild or even cure or normalized factor 8 and factor 9 levels. In Rotterdam, but also in other centers in the Netherlands, we collaborated again and included patients with severe hemophilia B. Now, nearly 10 years later, these patients are still producing factor 9, in this case is for patients with hemophilia B, and still have a treatment effect of this gene therapy. So they use prophylaxis, the coagulation factor concentrates, for 30 years, 20 years, depending on their age, and have to infuse that twice or 3 times a week. And at the time of gene therapy, their own body started to make factor 9, and they stopped prophylaxis and still have not resumed prophylaxis. So that was really, for these patients, complete change of their lives, improving quality of life. And in a second study that we also participated in, we had an engineered factor 9 was made in this product, which has a higher specific activity, which led to the a higher factor 9 level in these individuals, levels up to normal range for even 5 years now follow-up. So no bleedings or hardly any bleedings, no factor concentrate anymore after infusion of 30 minutes. And that is for these patients really a change in their lives. So it was, of course, fantastic to be part of such an initiative and treating the patients that you've seen for 20 years already. I've seen them grow up from boys 10, 12 years to adult males with families, and we could change their lives completely by gene therapy. So that is also,
very satisfying.
Yeah, definitely.
So gene therapy is for a few patients, no? Do you think it should be for more patients? Are there patients that would benefit from gene therapy that are not able to get it?
Yeah, the accessibility for gene therapy is still limited for hemophilia B. And there's one product that is now available in the US and also Europe. Fortunately, because of the high costs, it is not yet reimbursed in the Netherlands and also not in other countries in Europe. And so there's only a limited number of patients in other countries that have received commercially available gene therapy. And it also has to do with the fact that there are new treatments, other treatments, as I just mentioned, that compete. If that is less burdensome than, for instance, the infusion of your factor concentrates, and also has good results in reducing bleeding, then the choice between other therapy or gene therapy is mostly made to the other developed therapies, at least so far. And that is especially the case for hemophilia A, where the results of gene therapy are a little bit less good as for hemophilia B.
We want to go through your career. You were involved in the Dutch Hemophilia Society. What has been your experience?
So I was the chair of the Hemophilia Treaters Society in the Netherlands. So in that function, I was responsible for making guidelines for patients with hemophilia, but also other bleeding disorders. But we also developed a quality system for centers looking after patients with bleeding disorders. So at the time that I started, we had about 15 hospitals in the Netherlands that took care of those patients. Some of them had hundreds of patients, some had 10. And then we developed, based on the European principles of hemophilia care, we developed a quality system, and we came to 7 hemophilia treatment centers in the Netherlands, concentrating care by improving care and coordinating the care for these patients with rare bleeding disorders. So that improved, I think, quality of hemophilia care in the Netherlands. And still we have that quality system in place, doing audits yearly to make sure that the quality for care of these patients remains the same. So that was very important, I think.
Standardization for all patients in the Netherlands that they are.
So that if you are treated in the northern part of the Netherlands or the southern part, doesn't matter because you get the same kind of care. So that was an important achievement, I think. And I've also been involved in the Dutch Society of Thrombose and Hemostasis. And I think it's important to be part of those organizations because then you can organize a care for these patients, create awareness for the disorders, also for the general public, and make sure that the patients that you are taking care of and the diseases that you are interested in are well represented, will lead to better care for the patients.
What is your role now at EHA? What has been your involvement in EHA?
Yeah. So now I've been involved with EHA for many years. I've been a member of the scientific program committee or advisor for many congresses in the past, but I've been also a board member now in the past 4 years. And since June last year, I'm also in the executive board of EHA.
And what do you like about EHA? Why is it so important?
Again, it is important for our patients, for all the people that work in hematology, that they feel represented in Europe, not only in their own country, but also in Europe. For instance, now with the challenges of reducing funding for research, EHA still tries to fund a lot of young researchers by giving them grants. But we also have a European Affairs Committee, which is very involved in lobbying and taking care of hematology in Europe. For instance, in Brussels, where they ask for a lot of attention for patients with hematological disorders. So those are the things that I think are very important. EHA has grown over the years and becomes more active, also more visible in Europe, and thereby improving the situation for patients with hematological disorders.
It is important to bring together doctors, but also patients, and to raise visibility, exchange knowledge, I guess.
EHA has a lot of, let's say, tasks and various topics. So education of hematologists is very important, that we have the same knowledge in every country in Europe, but also abroad. Another important aspect is promoting research, but also take into account the patients. We have a patient advocacy committee, which is very important and is always present at meetings and is invited to give their opinion. And that is also, of course, important as a clinician, that you take also the position of the patients into account.
If I may say, I see a lot of fidelity in your career because you're really involved with patients. The diseases you treat, they are born with it and they live with them. And so you accompany them during their whole lives.
Yeah.
So yeah, there's a lot of fidelity in this. And also you came back to Erasmus. You have worked most of your life in the same place. You have the time to build the relationship with patients and with the staff and build something along the years. So I find that admirable. And for me, that's a takeaway from you. staying and taking care patiently of the same people during years must be really
Well,
positive and rewarding.
Yeah, I think it's for
Mhm.
most clinicians
Mhm,
that
mhm.
is the case. I mean, you always have a relationship with your patients in that sense that you know them for many years. You see them grow up. You get the highs and the lows of those patients. And if you can make their lives better by giving them a novel treatment, improved treatment, creating more awareness for their disorder, that is rewarding. And that is very important.
Yeah, but there are specialties where you see the patients just momentarily. So this is something specific for hematology and really interesting from my point of view. So is there something else that you would like to share with the audience?
I think one of the most important things is to collaborate if you are doing research. So you cannot do it by yourself. You have to collaborate with others to make impact and to be able to collect patients or to get access to new drugs that are available. I have collaborated with colleagues in the Netherlands. I've collaborated with a lot of patients but because they are important for our studies. We have good relationships with pharmaceutical companies that develop new drugs. We have collaborated with startups that, for instance, start with the gene therapy. So collaboration is vital for your research. And in the beginning, you think that you can do it by yourself, but that's not true. I mean, you need other people, and sometimes you have to share things. But I think at the end, it's a win-win situation, and that's there's one important thing is that you have to have people that you work with. So technicians, biochemists, PhD students. I've had great PhD students who did a lot of work in all those studies, each 4 years of their lives. That was actually the greatest achievement of seeing them grow during those 4 years. In their research, finishing a thesis and getting a career, whether it's in science or clinical medicine or outside the clinic, that is very rewarding and important. And I'm very proud of them, actually, that they all achieved that.
So somehow your career is the combination of all the efforts, yours, but all these people who have worked with you too.
Sure. Yeah,
That's,
without people that I've worked with, it wouldn't have been possible. No, definitely not.
Thank you very much for this conversation. Thank you for being with us today.
Thank you for having me and inviting me for this conversation.
And thank you to the audience for listening. If you enjoyed this podcast, please like it. And stay tuned for more episodes of EHA Unplugged.